All right, so happy Pride, everyone. I'm going to turn my camera on because I'm very proud to have on my Friends for Life. We take pride in our Liberty t-shirt. It's Friends for Life. I don't know if you'll see that. Because, and I'm so glad that Luke was able to make the call with us. And I know there are some other persons who are involved with Friends for Life because they have a very important part to play in our story tonight. Happy Pride. We're here on a Friday evening to discuss HIV PrEP. But the name is in itself a play on words because in recent times, while there's been discussion about the medication known as PrEP, what we really want to talk about is how do we continue to prepare our community, especially the younger ones, for a life in which we still have to deal with HIV. And tonight really is one in a series of online streams that PrideTT has undertaken, because this year for PRIDETT20 2.0, we are actually hoping to take Pride to another level by not only utilizing technology, but by actually implementing direct community intervention programs. One of those we launched with Brandy and the Trans Coalition on Sunday gone, where we basically kickstarted the Sasha Fierce Memorial Fund, and that fund aims to actually go into the community with the Trans Coalition and provide upskilling opportunities and career development, capacity development for members of the trans community. And that's what PrideTT wants to do from this year, is because I've said elsewhere that placards, protests, parties, and parades have a place, but our work must get into the community directly and also effect change. So tonight's live is the sixth in a number that started on Sunday. And over the last few nights, we've actually reached thousands of people, not only in Trinidad and Tobago, but across the globe. So our reach is building, and we have really grown by leaps and bounds in 3 years, which I think is something to be proud of, and I say that with the pun intended. And PrideTT tries our best to host as many activities that touch all of the niches within our community. I remember in the first year, I was criticized by some for hosting too many events, but we do not want to leave any segment of our community behind. And that is why on our calendar, sometimes you see upwards of 40, 50 events for the month. And tonight is one of those events, because I began my activism when I was 15 years old. David and Luke can bear me out on this, and maybe Brandy. I started with Danny James, and he was, of course, the publisher of the Free Forum magazine, which was funded by UNAIDS at that time. And we worked very closely with Friends for Life and others to advocate and bring awareness around HIV and all of the impacts that that had on our community. And I personally benefited a lot from that work. I remember being part of advocacy with people like Godfrey Seeley and Cyrus Sylvester, who, by the way, is on our Facebook Live tonight with us. So we remember people like Danny and Godfrey and so many others who did this work before us. And I always gave praise to Danny in particular for my activism, and helping. The work that I did with him is what helped me start Pride with so many other people in 2018. So that's what we're here to do, is to take Pride to another level, meet segments of our community, and really give them a voice and a space to discuss issues that are pertinent to them. So I will be the moderator for this evening's proceedings, and We have on our chat tonight Dr. Ayana Sebru, who will represent the NACC, and we have Mrs. Donna da Costa Martinez, who will represent FPATT. And of course, we also have Brandy Rodriguez of the Trans Coalition of Trinidad and Tobago, and David Soomarie, who is a long-time HIV and AIDS activist and an LGBTQI plus active advocate. You know, someone that we love and we sometimes miss, but he's joining us from Toronto, and we're very happy to have him as well. And we also have others on the call who will join us later on. But I wanted to start by giving Dr. Sebru and Mrs. Martinez an opportunity to really bring everyone up to date in terms of where we stand as a country in terms of HIV management, because there are still many persons in the community who are not aware, and this is a platform for them to leverage, to bring their message and their information to our community and so many others. And we have limited time with them tonight, because we really want to appreciate the fact that they've given us some of their personal time, and we you know, that is important, and it shows their commitment to the work that they are all trying to do and what we are trying to do. So we will start with Dr. Sebru and allow her to lay the land, as it were, for us. And depending on how much time we have with her, we may be able to ask 1 or 2 questions. And then I'll ask Mrs. Martinez to do the same before we actually start the panel. So obviously, if they can stay with us into the panel for a little bit, that would be great. But I can get into some more information afterwards, but I don't want to cut in too much more to their time. So having said all of that, Dr. Sebru, if I may ask you, actually I'll ask Brandy to give a short introduction to Dr. Sebru, because Brandy speaks so highly of her. And Brandy, after you do that, we can have Dr. Sebru engage us and we can go from there. All right? So I'll hand over to Brandy first and then Dr. Sebru.
Okay. Well, I must say good night, everyone. Introducing Dr. Sebru is, I've known Dr. Sebru since for a long, long time. Let's say long, we just say long, keep it there. She was not the technical director of a National AIDS Committee at the Secretary and the NACC. She was in other places when I knew her, but presently she's being the technical director of National AIDS Coordinating Committee. And I think the response to HIV could have been roughly nearly 2 decades. So, which means we have worked together, because in my 22 years of my advocacy work, I think we met early in my stages of my advocacy work. So I have had good response from her, and really, she's a person that really supports key population, and she understands where she actually tries to meet key population in their spaces. She understands where they are. So that's what I could say for now, but there's so much more, but that's it for now.
Thank you very much, Brandy. So, Dr. Sebru, we welcome you to our live.
Hello, good night, everyone. Can you hear me?
Yes, I'm hearing you. I think everyone else is.
Okay, good night, everyone. It's so great to see so many familiar faces. I'm in the middle of I can't turn on my camera tonight. I'm very, very sorry based on where I am. You're hearing all of the lovely chorus from Digger Martin. I don't know if those who are familiar with Digger Martin, you will know that we have lots of frogs, I think they say there, that make lots of noise in the night. So I hope that they don't cloud too much of what I have to say. Thank you, firstly, for inviting me to this forum to be able to share a little bit Brandy asked me to share a little bit about the NACC and to share a little bit about the HIV/AIDS epidemic from a key population perspective. So I will share a little bit, not as much as I would like, but I will share a little bit tonight. So the National AIDS Coordinating Committee was reestablished in at the end of 2015, and then we started having meetings into 2016, 2017 as a coordinating mechanism for the HIV response that was supposed to establish policy, support monitoring, evaluation of the epidemic, and is also a focal point for some of the agencies that are implementers. The major implementers of the HIV/AIDS response would be, which you would all experience, would be the Ministry of Health, Ministry of Labor.
We lost you. Hello?
Dr. Sibru?
We seem to have lost her.
Yeah, because it's on and off.
Oh, we're having some technical difficulties. Anybody has a number to call her?
Let me try. Let me call her.
Now, while we're waiting for Yana, Dr. Sibru to come back, I do know that some of you all are familiar with NACC, and some of you may not be, but it is the National AIDS Coordinating Committee, and I believe right now they are part of the Prime Minister's office. Okay, I think Dr. Sibru just rejoined us. Dr. Sibru?
Hi. Rudy, everyone, yes. Dr. Sibru is going to join us shortly.
Okay.
Just has some technical.
I think that's it. I think
can you
yes.
Can you hear me now?
Yes, we are hearing you, Dr. Sibru.
Okay. I need to log off from the other.
Right. We should have Dr. Sibru back on now.
Hello, good night.
Yes, I think you're good to go, Dr. Sibru.
All right, good night, everyone. Thank you again. I'm not sure how far you heard, but thank you for having me in this forum. I have the opportunity tonight to share on the National AIDS Coordinating Committee, which is the committee that was reestablished in the Office of the Prime Minister to coordinate the wider HIV/AIDS response. The National AIDS Coordinating Committee was established really to support the development of policy, to provide monitoring evaluation of the HIV/AIDS response, as well as to be a focal point for some of the implementing agencies that exist. Historically, this agency has also been the agency that would be involved in programs that have to be implemented nationally that involve more than one organization. So this is the NACC, and the major implementers now, which is separate and apart from what the NACC is supposed to do. We have some major implementers like the Ministry of Health, Ministry of Labor, Small Enterprise Development, Ministry of Education, Ministry of National Security, which used to play a much larger role in the past. We have major NGOs like the Medical Research Foundation and the Family Planning Association. And then we have all the other NGOs that support advocacy, prevention, treatment and care, psychosocial support. and ongoing treatment for persons living with HIV. So the HIV/AIDS response really has this kind of two-tiered approach, or it's meant to have a two-tiered approach, where you have separation between coordination and implementation. So this is how you would see, for example, the Ministry of Health, Ministry of Education, FPA, different organizations taking the lead in particular areas of the HIV and AIDS response. And this is where we are. So in a couple days, sometime next week, we'll be looking at data for the Global AIDS Report 2020, which will cover the 2019 data. And within that report, you will see some aspects of what happened in terms of the Trinidad and Tobago key population response for HIV and AIDS. And I'm going to focus a little bit on the key population response, just because it's not something that we discuss in terms of data all the time. If we zoom out a little bit, 47% of all new infections in the Caribbean, as reported by the UNAIDS fact sheet for 2018, were in people from key populations. And those key populations that were described as defined in that report were men who have sex with men, sex workers, and transgender, as well as intravenous drug users, which is not so much of an issue in Trinidad and Tobago, but we do have a significant crack cocaine substance abuse infection. In Trinidad and Tobago, we have had a survey looking at what is happening. We've had two surveys, in fact, looking at what happens in the population of men who have sex with men, looking at the HIV prevalence, as well as another survey that was recently done looking at what happens in the female sex worker population. And again, the prevalence in these communities is also fairly high. The female sex worker population is not so high. One of the surveys was done very, very early in the epidemic by Dr. Lee. And the survey that was done in 2015 was done by the Ministry of Health. And at that time, the prevalence in the men who have sex with men within the survey was about 26.7%. In the female sex worker survey, the prevalence was not as high, but that data will be reported as 4.9% for that particular study, and that data will be seen in the Global AIDS report that will come out next week. So we have some information about some of the subpopulations. The other subpopulation that we do have some information about is the population of people who use substances, and that's about 12.5%, but that's not been done in a national survey, so to speak. Last year, in 2019, we would have had about 635 people who would have started antiretroviral medication. As you know, medication in Trinidad and Tobago is free of cost to persons who would want to access medication. Testing is also free to people who would want to access treatment. But we have some sites that people preferentially access, and FPATT has been one of the sites that members of the key population also, that people have accessed as a preferential site, as well as some of the sites, for example, like the George Street site, the site in Arima, and some of the sites that have been shown to be accessed more by members of the key population than other sites. That there are other sites, but this is what the initial review of the data had shown at the time that we looked at it. That being said, we do know that some people still have challenges accessing treatment testing sites because of concerns about stigma and discrimination. And at times within the response, we have had members of civil society, many of the organizations who are within this group that help to navigate people who are interested in testing to get tested. And that has been a very, very important aspect of the response. And in fact, a lot of what many of the organizations do that are in this call is so very important in terms of helping people who may be at high risk or who may be infected actually get access to testing as well as access to prevention. Beyond that, persons access treatment at 5 treatment sites. We have treatment at the Medical Research Foundation. We have treatment at San Fernando General Hospital, treatment at Sangre Grande, treatment in the Tobago Health Promotion Clinic, as well as there's treatment at the Eric Williams site for adults at this time. So we have free treatment, and then the next step is being able to stay on treatment and be virally suppressed. At one point in time, we had the opportunity to look at a cascade specifically for people who identified as men who have sex with men. And in that cascade, where we looked at people who entered treatment, stayed on treatment, and attained treatment success, we were doing fairly well. So once somebody got into the system and somebody began to access treatment, we note that the majority of people moved on to viral suppression. If I had a little bit more time, I would have been able to dig up, to pull up some of that for you, but unfortunately, time did not permit. So back to the 635 people who are newly infected, 361 of those are male and 271 are female. It is noted that between 30 and 40% of people normally present with late disease, which means that persons would have automatically needed treatment in the past when we were deciding to treat persons based on whether their CD4 count was below 350 or not. At this particular point in time, Trinidad and Tobago has implemented what we call treat all, and so treatment is available for persons regardless of the status of their immune system. So once someone is diagnosed, they're encouraged to go on medication, and the importance of going on medication is to be able to achieve suppression of this virus, disease control, and treatment success, right? As well as being on medication now is going to reduce risk of transmission to partners. So, and treatment, so treatment is seen as a big part of prevention at this point in time. So in addition to being able to access free antiretroviral medication that's going to have an impact on your own health once you take medication, the other thing is that it will also have a significant impact on anyone else, so that disease transmission will be significantly reduced. And so then there's that opportunity to bring down the prevalence and incidence of HIV for persons who may not be infected. One of the things also to note is that of the persons presenting with new infections, the age group that is presenting with the highest amount of new cases is 25 to 34 for men and 25 to 44 for women. In men, the youngest case was between the age of 10 and 14, and the oldest case was over 60 years old. Right. The key population response really is heavily dependent on CSO activity, as well as external funding, a lot of which is sourced by the NGO groups. Now, that being said, that does not mean that the Ministry of Health and the government does provide free antiretroviral therapy, and through some of the programs that have been initiated with PEPFAR, as well as programs accessed through PANCAP and Global Fund, a lot of the programs that have been implemented in the national response through these programs have definitely benefited how the country programs the key populations. However, there's a significant amount of activity that is CSO-led and CSO-funded that is not really described. And so I'm sure if you share, you will begin to share when you share of your own work. you will be able to say, yes, we're doing navigation. This group is doing navigation. Somebody else had a testing event. Somebody else does psychosocial support. Somebody else providing emergency housing support. And all of those things are very, very critical things in terms of the prevention response, as well as the treatment response, because people need support from prevention to treatment and viral suppression, as well as the significant amount of advocacy for some of the projects and programs that are needed, as well as projects and response information that you provide as feedback to the national response to say, this is a gap, you'll need to fill it, we can't fill it, or we need help to fill it. That type of dialogue that occurs through advocacy, all of those things are also very important. And much of it is externally funded or locally funded through NGO efforts to source programmatic funds. So I'm going to stop there, except to say that there remains some significant gaps from what I can tell from where I sit in terms of what has to happen. One of the biggest things is the response for young people who are members of the key population, and how do we better serve their needs? How do we protect them? How do we make sure that their risk is reduced? As well as there are some wider gaps that we must address together. So I'll stop and just say thank you, and I'll stick around for a little bit in case anyone has any questions.
Thank you very much, Dr. Soomarie, for reminding some of us and informing others about exactly what is going on at a national level. And I personally know that you tried to give us the succinct version, because it's obviously many layers and it's a complex national effort. But I do believe people got a good sense as to what is going on. Perhaps I could ask one or two clarifying questions, and then we'll see in that time if any of you all have a question. You can frame it in your mind and you can come on and ask, or you can type it in the chat and we will ask it for you. So Dr. Seabrook, before you have to leave us tonight, you've been part of the coordination of this work for many years, and as you yourself intimated, you're familiar with the activities of many CSOs and NGOs and other groups that have been part of the HIV awareness and advocacy and management campaigns. You mentioned gaps though. What, if any, advice or programs, activities would you recommend the communities, the key population communities themselves, or persons who work with them undertake, or that we should support to fill those gaps? And I'm asking that from a very honest point of view, where we want to try and mobilize our communities and not only depend on the government, because that is, of course, the first port of entry, first port of call. Everyone looks at the government, but sometimes we have to see about our own. And what gaps, if any, do you think we should fill in our activities and programming to help us get to that zero goal?
Are you hearing me still? I'm working with.
Oh yes, we're hearing you.
Okay. Okay, great. So thank you again. I think the biggest thing, besides you know best, and I think one of the biggest things is being able to continue the dialogue with persons who may be able to support just the dialogue and say, okay, this is what I think the problem is. Okay, this could be a solution. And so being able to put all heads together to come up with new innovative solutions, I think that's one key thing. But one of the biggest things, I mean, in reviewing some of the data, we see that for people who enter treatment, people who enter tests, once they get tested and you test positive and you enter treatment, it seems as though people follow through. And so I think one of the biggest things the community can do is to bridge the testing gap. So in terms of getting tested, where you can get tested, you can go to FPATT or to wherever you feel comfortable getting tested, or even to, for example, if you have a private physician that you trust, you can get tested, as well as, and not just for HIV, but for other infections, because there seems to be a syphilis epidemic that is kind of underlying that I didn't mention tonight, and I'm sorry, but there is also a bit of syphilis stuff happening within the population that needs to be addressed. But that whole getting tested, getting screened at least once a year, and also encouraging your partner or your partners to get tested with you, encouraging younger members of the community to get tested, as well as supporting the walk. Because the other thing is that, okay, you get tested, and then if you are positive, you have to get from the testing site to start treatment, and that can be hard. And so, it's also important for you to be able to identify who your major supports are, and who's going to walk with you. So bridging the testing gap and then helping people to get from testing to treatment, I think that could be a big step, because if people who are positive get tested and get on treatment, that's a big step in terms of preventing new infections, as well as better quality of life, treatment success. And the earlier you get tested and earlier you get treatment, the better, in that your opportunity for other infections is going to be less. The psychosocial support from the community for the community is critical, because it's one thing to say get tested and get treatment, but it may not be as easy as it sounds. I know what it's like for me to go and get a test. And so it's really important that that the community provides support for the community to be able to make some of the changes that would need to be made, and be able to have candid conversations with people across all age brackets and all age groups about risk reduction and what can happen in terms of being able to assess your own risk for HIV and other STDs, and any other health risk for that matter. How do you take care of you? And have a conversation about that. And how you take care of you may change from day to day, but that's good, because people grow, and so you give yourself the space to grow. How do I take care of me today? Okay, I'm getting tested, I'm taking my partner, I'm eating less salt, I'm exercising, I'm not smoking, I'm using condoms, those things, and you develop your own risk reduction plan. But those are some of the things the community, I think, can do to really have impact in terms of what's happening for the HIV/AIDS epidemic locally.
Okay, I acknowledge Faye for a minute, just 1 minute, Faye, because Siobhan is with me and he asked. So Siobhan, if you can just ask Dr. Soomarie your question, and then I will take Faye's, okay?
Hi. So in 2016, well, this is I was gonna ask you this anyway, but like, since you talked about the syphilis epidemic, well, not epidemic, but issue that we have in Trinidad. In 2016, I thought I had syphilis, and I went with my partner to get tested, and they had said we didn't have any reagents, and they had no idea when we were going to get more. How long has this been going on? Because was the lack of reagents because of all the testing, and it was overstimulating the results that they had? Or like, can you give me like a timeline of how long you all been seeing this syphilis issue?
I believe there was a study that Dr. Edwards did. I want to say maybe, so we've we've been talking about what's been happening with syphilis and men who have sex with men since about maybe 2015, and in various ways. But because of how the system is designed, it's not always easy for us to be able to see if there are any downward trends or that kind of thing. It came up when there was a study that was done, I believe, looking at some data. I wish I could tell you that the amount of testing is the reason that we didn't have reagent at the time. But the two were not quite connected. I think there were some challenges at the time when you went to get tested, and so perhaps there was no reagent at that time. But getting persons in for HIV and syphilis testing is something that is encouraged. If you're not able to, if you I believe they should have reagents at this time at QPCCNC. I mean, Donna might be able to say, I haven't called. But generally, QPCCNC would be the site for syphilis testing, as well as they can also do HIV testing that's available in the public service. And if you are going privately, there's also opportunity to have a syphilis test done in the public sector, in the private sector, where you can have testing for HIV and syphilis done. Of course, if you're accessing care following through to the public sector, then they will follow through, they will do retesting, and then they will provide treatment.
All right, thank you very much, Dr. Soomarie. Faye, your question?
Dr. Soomarie, back in the day, at the height of probably the spread of the infection, there were things that would try to get testing done as much as possible. Testing parties. So there would be a party on, and the entrance to the party would be, you get a test. That would be your entrance fee. I'm just thinking of ways that, as you said, to fill this gap, we're getting people tested. What type of resources can an NGO like Friends for Life or PrideTT be able to access to try to fill these gaps? What support is there for that?
So this is a very different time. I'm going to start by saying that. However, if it is, for example, say Friends for Life or PrideTT was to have a testing party, and you anticipated that you wanted to try to have a party and you wanted to test X amount of people, what would be available is that you would then have to liaise with the prevention coordinator in the Ministry of Health, and they would then facilitate and arrange the free testing, so that as much as you're planning the party and having persons come to the party for a free test, you just include in that plan to just have as part of your coordination or your planning that interaction with the Ministry of Health's prevention coordinator to facilitate the access to testing.
So that's the step we'll have to go through. That's the department we'll have to go through.
Yes, unless, for example, so Ministry of Health prevention coordination, that team there, which is in the HIV/AIDS coordinating unit, as well as you can work with FPATT. FPATT also, and Donna can share more on this, I know Donna's there. FPATT also has worked with the community if you're doing a testing party, as well as Queen's Park Counseling Center, QPCCNC. They also will facilitate testing, but all three groups would need to know in advance that this would be what you're wanting to do, and the time and the amount of people to be tested.
Okay, thank you.
Dr. Soomarie, how long do we have with you again this evening? How many more minutes can you give us?
10.
Okay, no, that's fine. So let me ask this one as a bit of a follow-up. Because what we're trying to do tonight is, I mean, we can always engage, as you said, the ministry or NACC and the other partners after the fact to get more details. But as we have you on tonight, we're trying to just get an understanding of how things have changed over time, because many young people, they do not remember the era that Faye was referring to earlier. And you mentioned that testing, of course, is still important. But give us a quick idea over your span of time in the area. Has the community, in particular the vulnerable groups, the key populations, have you seen an uptake in their awareness and their testing? And as you said earlier, once they get tested, they get treatment, etc. Is the work real? Has it been having the impact? And are the numbers, even though one is too much, are the numbers today more manageable from what you're seeing? Like, can you give them a sense as to what came before and what you're seeing now, so that people can appreciate that trend?
I would say that I feel you should, I'm going to answer, but I think that you should ask that question again of Donna, as well as Luke. So I could say that for as long as that I have been around, even though I'm 21 for forever, the young people who are coming up now do not have the benefit of the information that the young people maybe 20 years ago may have had. In addition to that, there's new technology, there are new issues, and many of the young people now do not know what somebody who has HIV, who is ill, would look like. There's medication, so you can get HIV and you can get medication. So, okay. And so I feel that for a young person, the risk perception may be different. And that there are really other issues, some of which are explored and some of which have not been explored. I've been a young person for a while. And so some of the things that I hear them speaking about, I'm like, what are you talking about? You know? And so there is that intergenerational gap, and the design of the response to be able to capture that information and respond to that information on a day-to-day basis is not quite where it needs to be. So this is what I think that this is a big issue. We had a project recently that I don't think has been continued, that allowed for example, outreach on using technology. And I think that that's an important thing for a young person to be able to go online, assess their risk, go online, try and figure out where they could get tested and be able to interact with a navigator so that they can get tested. These things are things that are very, very important. Young people should be able to go online and be able to pull down information about HIV and AIDS treatment, STI treatment, and those kind of things online as it applies to Trinidad and Tobago. And we're working on some of those things. UNFPA and FPATT have a wonderful Youth Connect app that we are getting off the ground. And so there are things that are in the works, but there's still more that needs to be done. Once young people get tested and then have to access treatment, we also have that issue of psychosocial support. We have this issue of the legislation at this point in time in terms of how we support our young people and what we can do and what we can't do, that sometimes creates some problems for us. The psychosocial support is big, because if you don't have psychosocial support, it's difficult for you to move through the system in the way that you might need to. A long time ago, when I looked at the data for the young people that did well on treatment, it was the ones who had support. The ones who had support definitely were more likely to get viral suppression than those who, for example, just didn't have support. I remember very, very clearly a young transgender person who ran away from home, and the only person that looked for him was his grandmother, and she found him, and she took him for treatment, and he was diagnosed with HIV. But at that point in time, he was so ill that we were not able to save him with treatment. So even though we started treatment, he still succumbed to the disease. And so being able to catch our young people and move with them, I think is critical. And I think that there's that gap.
Now, this in no way is meant to be a trick question for you, but again, a very honest question. Everyone is aware of the fact that HIV status is not protected as it should be, in particular in the workplace, for example. What efforts have the NACC undertaken to provide support in that regard in particular? So apart from the testing and the medical side of it, in terms of the protections and education side of it, what efforts have been undertaken or are being undertaken?
Okay, so the part of the response that would deal with that aspect of the response is going to be from the Ministry of Labor and Small Enterprise Development. And so if you were to look on their website, for example, you would see that we have an HIV and AIDS workplace policy. And so the unit in the Ministry of Labor and Small Enterprise Development is responsible for now engaging with different employers to try and get them to conform to this HIV policy. And so they have been trying to work with groups to try and get them to manage the HIV/AIDS information in the workplace in a better way, as well as to manage a campaign for reduction of stigma and discrimination in the workplace. The NACC and the Ministry of Labor have also reached out to the Office of the CPO to try to look at the guidelines for HIV and AIDS in the workplace as well. And so that's some ongoing work that is being pursued. But the lead agency here is going to be the Ministry of Labor, Small Enterprise Development. The next step beyond the policy is to have a little bit of teeth to kind of get some legislation behind it. But the first aspect of it is the development of the policy, and I invite you to look on their website for the HIV and AIDS workplace policy.
Thank you very much for that. I think this is exactly why we're having this conversation, because people interchange agencies and sometimes the focus is misplaced on one agency or another. And as a community, you are really helping us to understand better where we can provide some citizen-led guidance. I'll put it that way. One other question that came through was quickly, what percentage of the national AIDS budget is allocated for vulnerable populations? And this question comes from David.
Can you repeat the question, please? I didn't hear what you said.
What percentage of the national AIDS budget is allocated for vulnerable populations?
That's a hard question, David. It's the budget is not, has not been captured in that way. When we did the national health accounts, if you look on the Ministry of Health, website, you will see that our national health account was done looking at using 2015 data, and in it will say how HIV/AIDS funding was spent for different groups. But when we looked at the HIV/AIDS budget, it was not quite captured to say what proportion is key population spent on key populations. The only way for us to be able to kind of, it would be less than 1%, I do believe, but you can't quote me on that. The majority of our HIV/AIDS spending is on treatment. And so treatment is available for everyone. So you would have to then go through and say, okay, X amount of treatment is provided for this population and that population. And so the budget really hasn't been broken down that way. The majority of our funds are spent on treatment. The projects for prevention, for key population programming and capacity building for agencies and stuff. A lot of it comes through the PEPFAR and Global Fund spend, as well as what civil society will capture from all the other agencies that would invest in the key population response. But I can't give you a proportion at this time.
All right, and one quick question, because the 10 minutes you promised us is about to end, and you can probably answer this and then segue into any closing remarks you'd like to leave with us. Just, by the way, just to let you know that Cyrus has endorsed your position about psychosocial support being of utmost importance, especially in these times with COVID-19, etc., given increased anxiety and those circumstances. So I know that people who are directly involved are agreeing with you. The question simply was, what can the private sector do to support the work of civil society and the government in this regard? And as I said, once you answer that, if you have any other closing remarks before we lose you tonight, we would welcome those. Dr. Seabrook.
I think, sorry, the private sector can, for example, support agencies that provide access to prevention and treatment. So, for example, provide additional supports to FPA for example, some of the projects that FPA may. Hello? Hello?
Yes, we're hearing you now.
So, for example, so what I'm saying is that for private sector could support a lot of the civil society-led projects. For example, projects that FPA may want to support to be able to provide greater testing and support to the community, as well as other programs for navigation, reestablishment of technologically based outreach mechanisms, sponsorships, for example, of some of the testing parties, education to some young people in different ways. I think there's an opportunity there for private sector to also provide some kind of a comprehensive education, comprehensive sexuality education to young persons once they are going that way, so that there are opportunities that way for investment in civil society, opportunities to sponsor outreach, education, social media activity, investment in novel ideas, technology, as well as for agencies who might want to provide additional psychosocial support. I think that's important. So I think with that, I just really want to congratulate you for hosting this particular forum. I'm going to try and stay on so I can listen to Donna a little bit and Cyrus. But this is very, very important. These types of conversations are very important for transfer of information, because there might be something that I know that may be useful to you, and there's something that you know that may be useful to me to be able to better serve everyone better. So thank you again for having me.
Thank you very much, Dr. Seabrook. We really appreciate you taking the time to be with us. And we have made a commitment to the community to continue these series after Pride. So we will be harassing you again with Brandy's help. But thank you very much for starting us off. With that, I would like to ask Brandy if she would do the honor of introducing her very good friend and associate, Mrs. Donna Da Costa Martinez, with whom we can engage afterwards for a little bit. Brandy?
Yes, I would introduce Mrs. Martinez, who I have known for a very long time and who I have a lot of respect for. Mrs. Martinez joined the Family Planning Association in 1985, and she became the executive director in 1990. And Mrs. Martinez have done a lot of work with key population over the years that I've known Mrs. Martinez. And I didn't know Mrs. Martinez as Mrs. Martinez. as donor. And I think the support she gives for sex workers and migrants and for the LGBTI community really tells a lot. And the compassion and care that she shows in terms of what is needed, because she always asks, I don't know everything. I really don't know. Could you help? Always ask for support and always collaborate with persons who are doing the groundwork. I think she has shown a lot in terms of changing the dynamics of FPA over the years I've been with her, and to give support and lend and education and access to care and treatment without stigma and discrimination for key populations. So that's it, what I could say for Mrs. Martinez, and she could say the rest for herself.
Thank you, Brandy. So, Mrs. Martinez, perhaps as Dr. Sebru did, you can provide our audience with a lay of the land, so to speak. Tell us about FPATT, what you've been doing in the area of HIV and AIDS, and what you are currently looking at, and the projects and programs, and we can take it from there.
Yeah. Okay, so thank you very much, Brandy and Rudy, for inviting me to participate in this session. I want to say a special good night to all my friends who are on this webinar tonight. You know, we have had a very long relationship with a number of the representatives here. You know, I recognize, apart from the fact that I've known Brandy for since 2006. I know I was in another forum the other day, and I made a mistake and said I knew her since 2015, which is not true. I knew Brandy since 2006 when we undertook a sex work project. We have had relationships as well with Friends for Life, Luke in particular, David from CARE. So it was so good to see David on. Kennedy and the others, I see you all are there as well. So good night to all of you, and a special good night to my colleague from Ayana from the NACC. Even though the Family Planning Association is no longer represented on the NACC, you know, we do work very, very closely with Ayana. I think Ayana has that kind of personality to engage you no matter what. So we work very close with the NACC and with the Ministry of Health. But I think it is important for me to share a little bit about the Family Planning Association, because I'm saddened sometimes when people tell me that they don't hear about us or they don't know what we do. But the Family Planning Association of Trinidad and Tobago is a non-governmental organization. I know most people think that we are government, but we are a non-governmental organization providing sexual and reproductive health care to men, women, and young people. Our mission is really to advance a society-wide agenda by uniting with stakeholders to champion sexual and reproductive health services and rights for all, especially the underserved. We were established in 1956, so more than 60 years ago. We are the oldest local NGO working to advance sexual and reproductive health and rights in Trinidad and Tobago, and by extension, the Caribbean. Locally, FPATT falls under the purview of the Ministry of Social Development and Family Services. Also, we are a member association of the International Planned Parenthood Federation, which is known as IPPF, and they are a global service provider and leading advocate of sexual and reproductive health and rights for all in over 170 countries. FPATT has 4 clinics situated across Trinidad and Tobago. Our locations include 2 major sites in North and South Trinidad and another in Tobago. And they are all designed to maximize patient confidentiality and a quality healthcare service experience. We also pride ourselves in our one-of-a-kind clinic called the Living Room. which was designed and caters to the unique needs of at-risk young people and other high-risk vulnerable groups. Most of the persons that we, most of the clients that we serve would know, especially from the LGBTQI community, would know the living room, because it's a very friendly environment, and so, and most of them prefer to be served in that room. We also boast a mobile outreach program which provides services to underserved communities throughout the country. The FPATT is one of the most well-respected agencies in Trinidad and Tobago and acknowledged by the government and many civil society peers as a leader in the delivery of quality, cost-effective healthcare services, while our emphasis and forte has been sexual and reproductive health and rights. Our foundation is set in a, how I describe this, in a human rights approach. So in recent years, we have been building a portfolio addressing the basic healthcare needs of young people and children. Each year, FPATT engages a minimum of 7,000 unique clients who benefit from a minimum average of 78,000 healthcare services delivered at one of our service delivery points. Historically, FPATT has been an invaluable contributor and advocate and continues to do so for the development and/or amendment of law, policies, strategy documents, and other national legally binding instruments directly associated with basic and fundamental human rights. Over our yearly 7,000 plus unique clients present a diversity of behaviors and socio-demographic backgrounds, and many of them belong to the most disenfranchised, forgotten, or hard to reach communities, key and vulnerable groups. In terms of the services that we provide, FPA has a suite of services which consists of contraceptive services. We do have special packages for females and males, so that a female health package would consist of a pap smear, breast examination, other kinds of tests for NCDs and so on. And we also have a male package for where we do prostate, the screening of the prostate for cancer. In addition, we do STI screenings, we do chlamydia and gonorrhea, and we also do HIV testing. We also do a lot of counseling and so on. A major part of our work also involves going out into the communities. So, and more recently, we have been looking after the migrant community, attending to their needs, and this is in collaboration with organizations like UNFPA and UNHCR and other non-governmental organizations. In 2016, we were part of which really anchored our work in HIV. In 2016, we were a partner with the Linkages program, and that was not, and a basic part of that had to do with a peer navigation and bringing persons into the organization to test and then navigating them through the health services. And again, that's where we were in connection with a number of the civil society representatives on the call. Unfortunately for us, that was short-lived. That whole project was short-lived because of the fact that Trump had come into, had become the president, and that they had overturned the gag rule, so that they were no longer funding from any US agency, could no longer go to the Family Planning Association of Trinidad, of any family planning association across the world. So that we had to end our relationship with that particular project. But we didn't end the work that we were doing. our clients still continue to come to the Family Plan Association. Ayana had mentioned earlier that we are just one of the preferred providers. There are places that the vulnerable communities, representatives from the LGBTQI community and other persons that we work with, that they would have their preferences. We're happy that people like the service that we offer, so that we've been looking more recently at how we can expand our suite of services as it relates to HIV and support the government's program, especially in achieving its targets and so on. And one of the things that we had in 2018, we were, an assessment was done of the Family Planning Association by PAHO, WHO, and representatives from the Ministry of Health to determine whether FPA had what it took, what is necessary in order to be included as another NGO site for treatment. I would like to say that that was met very favorably. However, there have been some delays in getting that off the ground. The government, the Ministry of Health in particular, just before COVID, was trying to engage with us in order that we could present a proposal that we would be able to fast track this opportunity. We see this as a very good move, because it means when clients come to us, they have another option of seeking treatment. So we're hoping that once everything settled down with COVID, that we could continue to spearhead this and to ensure that there is another choice offered to persons who turn out to be HIV positive. One of the reasons that one of the other things that we are looking at is how, because a number of persons have approached us and asked us about PrEP, and I'm very glad that Ayana has stayed on, because I'm not a medical doctor, and therefore questions related to that. I wish, Alana, that you could just hold on for just a few more minutes, so that in terms of a medical perspective, if there are any questions. So as you all know, PrEP stands for pre-exposure prophylaxis, and it's an HIV prevention strategy where HIV negative individuals take anti-HIV medication before coming into contact with HIV to reduce their risk of becoming infected. More and more, PrEP has been widely spoken about. We've been asked to step in to see whether this is another service that we can provide. We do understand that it tends to be a very costly service. Just excuse me 1 second, please. Just one second. I'm sorry about this, because they're trying to get my granddaughter her mother is trying to get her, and nobody's answering the rest of the phone. So she's constantly pressing my sending a WhatsApp. So let me just say one thing quickly. I beg your pardon.
Just a reminder, if you all have any questions for Mrs. Martinez, you can send them in the chat, or you can ask them. You can put your hand up and we'll acknowledge you once she's finished with her opening remarks.
Okay, my apologies again. Yeah, so PrEP is something that we are going to look at, but we just can't introduce PrEP without having the necessary information for us to be able to see whether it is feasible to introduce it, because you have to have a clientele. So one of the things that we would like to do and to engage with you is during your testing, when you do your testing for your Pride event, we would really like to send out a questionnaire to people for us to get a sense of how people feel about PrEP, whether PrEP is something that they really want to have as an option, and asking some basic demographic some basic demographic information. Yeah, basic information about, so that will help us determine whether there's a need. This is definitely something, however, if it turns out that people are really interested in having PrEP, it means that we'll have to build a proposal. We'll have to build a proposal for introducing PrEP into our services. So I really would like if you all could assist us in filling out. It's going to be a very short questionnaire because basically we might be asking basic things, you know, general information that from which we can do an analysis in order to be able to determine the next move. Apart from that, we have been working with Rudy and Pride and all the other organizations in order to, because we feel that the work that you do fits very well into our context in terms of the human rights issue, our advocacy strategies and so. And therefore we're trying to see how we could forge the partnership, strengthen the partnership in terms of being able to do more work together, putting it within the context of sexual and reproductive health and rights. And so we have been engaging with Brandy and other representatives amongst the group in order that we can continue to support you in your work and advocate for some of the issues that you are advocating for, since we see that these are very closely connected to the issue of sexual rights. So basically, I want to stop there and to see if you have any questions to ask, particularly in relation to the issues around PrEP and where we want to go with that.
Thank you very much, Mrs. Martinez. Actually, well, for those who may not know, for Ida Hobbit this year, we did partner with FPATT and IPPF, and we had people think I'm making this up, Mrs. Martinez, but in less than 22 hours, we organized that event and we had over 60 persons attend. And the data we got from it was very revealing, and we do have plans to execute additional programming with you. But we along with that commitment, we have had a long-standing one to support the survey on PrEP, and we want to pick that back up, if not during Pride Month, but definitely right after. So I'm glad that you brought it up on the call so that the members of the community can hear firsthand how important participating in the surveys and the workshops, etc. are. So let me pick up right there then on this matter, which has become a bit of a controversy in the national dialogue. Again, not to put you on the spot, but as one of the NGOs which has been supporting the idea, at least, of introducing PrEP, why do you think there has been a less than proportionate response from policymakers on this issue? And what would you say to them to help them get over any barriers that they have in their mind as to the importance of supporting something like this, in whatever way that support takes? But if even it's only at a policy level, of course. But what would you say to them, and why do you think that's the problem?
I think, let me say that, there are always various reasons, even from a policy level, why things cannot be done. And you would recall that FPA had put out a statement around PrEP when PrEP was being associated with the fact that, it was going to be used as the opportunity for people to become promiscuous. I think we have to put all of this into context. And if we are looking at it from an HIV prevention strategy, I think it is important, even if we are not at the national level able to support PrEP, there are organizations like Family Planning Association that that given the right resources and so would be able to implement some of these, what I think are very important programs. Everybody, you know, knows, the literature is out there, that PrEP is a prevention strategy that will guard against HIV. But there may be several reasons, and I think we have to move away from our own feelings, you know, personal feelings and moral, you know, this moralistic approach that we take sometimes when we address in these issues, and really look at it from the context of what it is meant to benefit the country, what is meant to benefit those persons who do not want to become HIV positive and who feels that this is an option. I understand that that maybe from a policy level, and I don't want to put Ayan on the spot if she's still there, that the issue is really one of cost. And I think it is important that when we are talking about these issues, that we put it into context. And if it is one of cost, then clearly it's something that one could rationalize. So that if we are saying, for instance, that already the budget for purchasing HIV medication, which is the same medication that you are going to be using for PrEP, that the priority is to ensure that those persons who are to be treated are the ones who have first take at the medication. You know, that's understandable. But I think we have to think about persons' sexual rights and putting it into the context of promiscuity. And so I think it's really not really going down the wrong road. And to understand that if we want to really beat the targets and to achieve our 2030 targets for HIV, that we ought to be more open-minded and look at more other approaches that will help us to keep the rate of HIV infection down. And I feel, you know, it calls for persons who could go beyond this moralistic stance and take into consideration people's rights.
Mrs. Martinez, thank you so much for being frank about this issue, because it is something, as you say, that is grounded sometimes in people's own perspectives of how they think people should be living their lives, etc. And David is reminding us in the chat that, of course, PrEP is also an important option for serodiscordant couples. I myself, my first partner was positive, and back then we didn't even have some of the programs that Dr. Sebrew and you are speaking about now. And I remember the anxiety at that time of being in a relationship like that. Thankfully, as Cyrus and others mentioned, we had some psychosocial support from within our own community that assisted us to navigate that. But PrEP would have been a safeguard, if you will, should anything have happened that would have, you know, assisted us in remaining serodiscordant, whereas we just had to, and this is a deliberate jab I made. I had a conversation recently with some evangelists on another call, and I told them, I said, I don't know, maybe you all are having a lot of sex more than I do, because in my relationship, sometimes I don't even have time to have sex for the whole week. So our approach to remaining serodiscordant had a lot to do with celibacy at that time, because that was the information, unfortunately, that was available, and we didn't have PrEP as an option. So thank you very much for sharing that. And Renelle, just for clarity, Renelle is asking, so is PrEP available at all? Can someone get it privately? And I know that that is a question that other persons in the community have asked. Do you have any information on that you can share?
Well, HIV drugs are, I mean, it's available through the government, but it's not to be used for PrEP. Ariana could correct me if I'm wrong. And I also do think I've known of persons who have purchased PrEP from abroad. But you know, the sustainability of that in terms of being able to access and pay the cost of it, I think it is hard for some people. And therefore, I always feel if there is a program where we could capitalize on economies of scale, because the more people who are able to go onto it would be better for would keep the cost of overall medication down, I would think. I don't know if Ayana is still there and if she could actually respond to that, but I know there are people who would source their medication from abroad.
Hello?
Yes.
Hello?
Ayana?
Hi.
Yes.
I'm still here. I was just about to come out, but
all right, please. Oh gosh, just stay on for a little bit.
I'm past my time. I'm gonna get cut out now. But with PrEP, one of the things I think that's important, about 2015 into 2016 is when we implemented Treat All, and that was a big thing. And so we had to be able to bridge that gap. PrEP is part of comprehensive prevention. I think that's an important part to note. And so treatment of people who are HIV positive is part of that, as well as the whole issue of the condom, the use of condoms, the information and access to testing and retesting for HIV, STIs, and other things, as well as PEP and PrEP. Now, so access to PrEP and access to a PrEP program are two separate things. I think it's important to note that just accessing the medication and taking medication is just one piece of it. But the prevention that comes with access to a PrEP program is critical. So you don't kind of want to shortchange yourself, because there's that whole opportunity for engagement around STI screening as well as HIV screening. That's very, very important, as well as making sure that the person that you haven't converted, there's the issue of adherence to PrEP. So a PrEP program, I think, is important to come with access to PrEP. There are people that I am aware of who have accessed PrEP in other countries, who live here. They go away, they get their PrEP, and they come back. But they are in going away to get your PrEP, you're actually engaging in a PrEP program. And the program is that access to wider prevention that I think is an important part of the process. For us, from a national perspective, in terms of implementation of wider PrEP, there would be that need to do exactly what Donna is speaking of, in terms of getting a sense of who the clientele will be, how many people, will people be willing to pay, not pay, as well as making sure that, for example, some of the testing that may need to be done to support somebody accessing PrEP is available to screen for STIs, to give, timely results, as well as to have a wide enough panel, as well as the available treatment should anybody seroconvert for any STI, not just HIV. So I think that what FPATT is now doing is that piece which we actually started doing and stopped, which is that feasibility study to say, okay, fine, if we're going to implement PrEP, what else do we need to have? Who's going to be engaged with it? That piece, and that is the next step for us. Yes, a policy position is important. Some physicians and clinicians may make a decision to treat serodiscordant couples. That's, of course, at the discretion of the clinician. But from a policy perspective, the government has decided not to go with PrEP at this particular point in time. But the step that Donna is taking, that FPATT is taking, is the next step. Where is the community? What services are needed? What is the capacity of FPATT or any other group agency to support PrEP implementation? what's available and what would the investment need to be. And of course, a year ahead of time, how many people would additionally need to be catered for to be able to ensure that you have adequate medication available to provide for the persons who are coming to access the service. So I hope that kind of gives a sense of PrEP from a policy perspective, at least from where I sit at this time. In terms of,
Go ahead, Ayana.
In terms of a PrEP program, as opposed to just accessing the antiretroviral medication.
Yeah.
I think that it needs to be within a comprehensive prevention. PrEP is part of comprehensive prevention. To remove it from that puts the person accessing the PrEP at risk of other things.
Yeah. And I totally agree. I totally agree with you. It's just not like popping, putting another pill as part of a whole set of a repertoire of pills that you have to take for a particular problem. And the program itself is what is going to be critical to ensure that persons are, their health is always that their health is always paramount. And I think, what I want to say is that really and truly, if we are to progress,
Yes.
the health sector response to HIV has been critical to the achievement of universal health coverage, which is one of the key, as you all know, is one of the key health targets of the Sustainable Development Goals. I think it is extremely critical that the citizens of Trinidad and Tobago can access the medicines they need when and where they need them. And therefore it is in that context that we are looking at this whole, we would like to look at the whole issue of PrEP. And it's not as if FPA is going to, we would want to know that even if the government at this time, let's say, cannot do such a program, that they will support the non-governmental organizations such as FPATT to ensure that it's introducing other measures that will help us to keep the HIV infection rates down.
Mrs. Martinez, the interesting thing is we are also running a needs assessment survey because this year is, of course, and everyone heard today that the elections are actually in August. Because it was an election year, we planned to develop an empowerment manifesto, which is collating data points from not just the LGBTQI community, but also other marginalized groups to present to political parties in a bid to have them change their policy to favor citizens of the country. So we will share that data with you as well. And we will, and that's exactly what you're talking about, is what we're trying to do with partnership, with organizations such as yourself. And of course, another important organization that you've been working with is, of course, the Trans Coalition of Trinidad and Tobago. And Brandy, I wanted to bring you in here for a moment. Now, Mrs. Martinez, how long do we have you on for again?
I know not very, very long. You see, I lost some time already with my granddaughter, and I had planned to do just what Faye was talking about my business earlier, and I'm still going. So
let's have you for maybe 5 to 10 more minutes, and then we'll segue. So I want to bring Brandy in before you head out, because I think it's also important for the rest of the community to understand some of the conversations. When we talk about key populations, the trans community is and remains the most marginalized segment in our community. Brandy, tell us and share, you and Mrs. Martinez can share with us a little discourse right now, dialogue, on what are some of the projects that you are working on with FPATT and why those projects are important, and how can the rest of the community support you and FPATT in those programs?
Okay, firstly, I must say, apart from Mrs. Martinez running a really good, successful NGO, she's a full-time grandmother, so we understand. I really, really appreciate the time and energy you put out tonight, because I know we talked about this earlier. But aside of that, some of the projects that actually and programs that the Trans Coalition and with partnering with FPA is really to get key populations, put key populations in a space where they where most of the SRH questions is being, asked and treated. Most of the times we have a lot of disconnections where persons from key populations don't be tested. There is no space, there is no accommodation, there is no conversation for key populations. And also, my thing is that engaging, asking the UNHCR for supporting funding through FPATT, who has the clinic and the space to accommodate some of these services. From time to time, we work together because we know that the key populations, the TLGB community, and we have the sex workers, we have the migrants, we have PLHIV, and also I want to add to when we went to this meeting in November, the inclusivity meeting with the British High Commissioner, we met persons who were from different spaces, like the deaf, the blind, and the wheelchair-bounded persons who were willing to access services. And this is where we engage the conversation with FPATT, who has the, so given the information for support. And it's not just about HIV, but it's also about sexual reproductive health and their rights. So this is what we have actually had this discussion, and I also want to engage with PrideTT also this year so that we could, have a different conversation in terms of PrEP to see, because we just want to make sure that we get some information and support from the HIV perspective and PrEP in this, because last year I think although we did PrideTT for the last 2 years, I didn't think we had that initiative to get around to HIV, and I really didn't want the 2020 to go or start without having this conversation. Because what I want to do is engage with 3 sites in Trinidad, which is one in the north, one in the south central, and one in Tobago, to get persons around, having been tested, which Wade and I have completed the email. And I'm sorry that Wade is not here right now, because we had to copy Dr. Sibro on it and also send it to the HACU, Dr. Antoine, to set up these sites, and so we could collaborate the appointments to make sure we have these conversations and do the survey for persons to respond. Because as you said, Rudy, it's an election year and we would like to collect as much information. And PrEP has been a discussion where we had our Minister of Health saying, in no uncertain terms, that, this is the government, and I'm really surprised with this government, because this government has really worked with HIV over the years. They have really put HIV budget, budgeting into HIV over the years. And I'm really surprised to see that the conversation around PrEP is not happening. And he was also one of the champion for change by PANCAP over the years. And these are people who said that they're going to make sure and, work around change. And that has been one of the things that we see, in terms of changing the dynamics, in terms of stigma and discrimination. So this is what Mrs. Martinez and we want to engage now with PRIDE to end stigma and discrimination and have persons access services in spaces where they feel most comfortable.
Thank you very much, Brandy. So, Mrs. Martinez, before you head out to continue your grandmotherly duties, and on behalf of the younger ones of the community, you've been helping to save our lives for many years. and that's one of the things grandmothers do. So you probably have many more grandchildren than you know about out there. But having heard what Brandy said and knowing of some of the concerns of the community, I mean, you've done work with Kennedy and Jeremy and they at Silver Lining Foundation. You obviously do work with Luke and they at Friends for Life, AJD, Kaiso, others over the years. What, and Bohemia, I'm sure as well, in wrapping up your call to action, as it were, what would you leave us with, leave the community with and others as a call to action or any advice or guidance that you would give us so that we can continue to work with key populations and support them and at the same time move this needle further into the realm of policy that supports the initiatives required to truly reach that zero mark for HIV and AIDS. Sorry, Mrs. Martinez, just unmute.
Sorry, that's a very interesting question. And I think I am heartened by what I've been seeing over the last couple of months in terms of how the groups have been coming together, the trans, all the groups, and how they're beginning to talk in a way that gives me much more hope, because I think this is the way it has to be done. The funding remains very limited in terms of HIV now, and now that we have COVID, you all will very well understand what's going to happen. But I think you all are on the right path. The collaboration, strengthening the collaboration, and joining together as groups to capitalize on what funding is there to serve the communities, I think is very critical. And I'm really very heartened to see that this is how this is happening, and how all the various groups are coming together to do so. So organizations like the Family Planning Association, we would, like to be very much an integral part of the work, because as I say, what you do, what your needs are, fits very well into the mandate of the Family Planning Association as a sexual and reproductive health and rights organization. And I think you are stronger in numbers, and therefore there is no room anymore for us to, be pulling away and pulling at different things, and we don't like this. We are all professionals, and I think it is important that we come together as a group to do what we know to do best, to advocate for the rights of all the communities, to be able to have a more satisfying sexual life, and also to ensure that all their sexual and reproductive health needs are met. HIV is an integral part of sexual and reproductive health, and that is why years ago the call went out to ensure that it is integrated, it's not seen as two different things. So I would want to encourage you. As I said, I'm very heartened by what I'm seeing. I don't think there's a day that you all don't meet, and whatever is happening, the groups are coming together and getting involved. And I think we should use Pride again as this opportunity to demonstrate that you are a force, that you are going to stand up and advocate for what your needs are, and that with other organizations, civil society organizations like the Family Planning Association, we stand ready to support and to work with you for the interests of all in the communities.
Wow, Brandy, you hear? Well, Brandy knows that Brandy is like one of your biggest fans. And Brandy, what do you say? I mean, I'm sure you said it before, but what do you say to? I mean, what can we say to that other than thank you, right? I mean, that's
yes. I must say thank you, and I know we didn't negotiate for all of this, but it's nothing. We just glad for the opportunity that we share the information that you share, because I know in moving forward, it would benefit everyone, and the information that the support that you give it was really, really a fantastic one, and we want to see how best we could collaborate, because as you rightfully said, with this COVID response, we definitely know what's going to happen, but we have to keep together and keep the focus in order for us to, you know, be able to say, well, this is what we want and this is how we want to move forward.
Yeah.
So I thank you. I really, really thank you again. And also, Dr. Sibru said for me to tell her that, tell everyone that she has left. And Brandy, please don't disturb me. But you know, tomorrow I will be calling her again. So, but anyway, I really, really thank you for this. And we'll see how we could best work together. Thanks again.
Well, I really thank you, Brandy, because you know you're one person that you could never say no to. I want to use this as a plug for all those people who have left us. We have space back home, and we will welcome them back to Trinidad and Tobago to make their contribution here and not elsewhere. So read between the lines.
Oh dear, I think
David, I love you, and I will always love you.
thank you very much, Mrs. Martinez, and I know you have to go, so
Yes.
we will keep in touch. And as
Yes.
I said, we are an organization. We will share all of our information and data with
Yes.
you and any others. So we will keep our discussions going and our
Yeah.
joint initiatives.
Yeah.
Do enjoy.
So what I will do is that we'll try to come up with a very short questionnaire that will at least be able to give us the information we need so that together we could determine whether the introduction of, you know, whether we could at least pilot test PrEP as we move forward. So I will, of course, liaise with Ayana and the other members, Brandy, yourself, and so, to see how we could compile a small questionnaire. And all we would like to do is encourage all the persons who do their testing at the sites, if they could take the time to respond to it. And it could be a SurveyMonkey type thing so that they don't really have to sit down and write. So we can talk a little more about that in the days ahead.
Wonderful.
And I want to wish you all the best in all your planning activities for PrideTT. I think this one is going to be the biggest and the brightest ever, especially in this year of election, when August 10th.
10. Thank you so much. Enjoy the rest of your evening.
Thank you so
You can
much.
be safe, and we'll be in touch.
Yes. Okay, thank you. Bye-bye.
So,
Bye, Mrs. Martinez.
Bye.
everyone else, our family here, that is a perfect opportunity for us to bring David and Luke into the conversation. And really, it's been a couple hours, well, but like most of these discussions that we've been having, this is really an opportunity, as I said at the beginning, to document this information, which is sometimes in all of our heads, so that people can reference it later on. And so Brandy, Luke, David, we've heard now, we've spent the last hour and a half or so listening to the policy, listening to some of the programming from a very important partner, the FPATT. But you all have been in the trenches on both sides of this work. You have worked within the NGO field, and you've worked on the ground with the vulnerable groups yourselves. Let's bring David in for a moment here. David, you now operate in Toronto, but before you left our shores, as Miss Martinez was just teasing you, you obviously did a lot of work here with us. I remember when you were at CARE, for example. Tell us a little bit about, before all these new policies and these new ideas and technology, what was it like for you advocating and doing work in the field of HIV and AIDS? Give us that insight. Tell us your story a little bit.
Okay, hi, good night, everyone. Thank you for having me. It's really a pleasure to be here. I live in Toronto, but my heart's still in Trinidad, and I love all of you. It's good to see all of you here. And I want to start by acknowledging, and I think it's important that we always acknowledge those who paved the way and those who've done incredible work to lay the foundation for where we are now. And if I call names and the names that are missing, please do accept my apologies. But I would like to take note of people like Godfrey Seeley, Jeffrey Stanford, Catherine Williams. These people have been very instrumental in the early HIV/AIDS response. Also, Friends for Life played a very pivotal role in terms of caring for gay men who were put out of the streets and who needed a particular kind of care around AIDS and managing treatment and access. When I came in as a person living with HIV, I was fortunate in the sense that I came in at the end of one wave and at the beginning of another. The wave that I came into was a wave where people had little or no access to medication, and they were getting medications for their friends and families who were sending it from abroad, and they were taking like lots of these medications that were not working with their bodies. And there were very physical signs of people who had these complications. You could see it, you could tell. They had this kind of skin, the bone, I can't remember the medical name for it, but their face were drawn, they looked limp, they looked a particular way. I remember seeing Jeffrey Stanford with a red mark on his neck at one point in time. There were these very visible signs you could have told that there were people who were infected with what you call back then AIDS. When I was diagnosed, I remember seeing a lot of the signs. I remember the particular sign on City Gate, all places on City Gate in the transport hub that read AIDS equals death. As a young gay man who was dealing with his diagnosis, to see that sign every day was a reminder to me that I was going to die. I did not send a very strong message. I'm grateful to CARE for being that organization that has helped me become healthy. It's through the intervention of Amy Brown, Dr. Amy Brown, for instance, and Nellie Lewis Agard. These folks who spoke to me one-on-one and gave me the kind of support that I needed to access medication. When I came out as a person living with HIV, there's a lot of stigma around. People were like, didn't want to touch you. They would talk about food, not eating from you. There was this very clear association that you're gay and queer. Having HIV or AIDS was a direct result of living that lifestyle. When I started treatment back then, in my early days, I was taking like 12 pills in the very beginning, and then moved to 2 pills, and now I'm on 1 pill. And so that's kind of like some of the advances that we have made. That's it, really.
Wow, David. No, sorry, it's just when you talk, some of us were around. I mean, I was at the back end of it, not to put anybody on the spot, but we have like Anthony's here with us, and he obviously would have been Faye. Cyrus is on the live. You all would have been around before us, David, myself, Luke. You all saw it firsthand, and it just when I listen to these stories, it brings back like that messaging that you referenced was so off. It was looking, they say hindsight is 20/20, but obviously they meant it in a manner to frighten people so that they would change what they saw as behavioral patterns that led to it. But well, Anthony's now saying, he's reminding me that you want to come in.
David, you would second this. They didn't know what HIV was. Something was just killing all of us. And I remember my ex, Frank Ali, lived then in LA. And his, and I got this from friends, of course. We still kept in touch, and of course he got HIV from his boyfriend and all that. Was in hospital, and they had a sign over his bed: "Do not give." And this is in New York and LA. Do not give food or drink to this patient. They starved and killed him because he was HIV positive, and they didn't understand it. That's what happened. That is what. Down here, I went to Cowra with, gosh, a gorgeous guy, wore makeup and took very good care of himself, always well dressed, Russell Fleming. He worked with Wayne Barclay. He, of course, was HIV positive. He had lots of little young boys around him and stuff like that. And he was divine. And he had tried every hospital and they turned him away in Trinidad, every nursing home. And it was Dr. Adu, an African doctor who was here, who got him into Cora. And he asked, would I please come and cut his hair? And I said, of course, I know Russell, what the hell? I did not know, I didn't understand HIV. And when I went up, he was shivering on the bed because Cora doesn't allow blankets or anything like that. Of course, a chest hospital, so nothing with furriness that could, you know, damage your airways or whatever. So he was, you know, like that, and on the bed. And the nurses, what I said, come, let's go outside. Outside looks so nice and sunny. We get such lovely ground. Let me go outside and cut your hair instead. And he was still joking in all his agony or whatever, still joking. Oh, look at that lovely orderly there. And I said, hello, boy, behave yourself, you know, things like that. And I cut his hair in the garden, but it was the wrong decision, because just the slight breeze out there sent him into hell. When he went back on the bed, Gregory, my brother, Christopher Santos, and I lay on the bed and hugged him to try and put some warmth in his body. He kept clutching his little cotton pajamas, and the nurses trying to tear it down to sap him with alcohol to warm him up. It was awful to watch, right? And do you know, he was then sleeping in a body bag. That was his bed. And Dr. Adu is a nice one. And he said, he gave him signs to look for when you bring up your insides, whatever it was at that time. Then you know you're near the end. Do you have a message for anyone? And he said, Dr. Adu, I just want to say thank you very much. Because his family threw him out, they threw out his books, they didn't want the children to touch any of his things. My brother and Chris Santos buried that boy, not his freaking family. You understand? And that day, after I cut his hair and all that, shortly after that, he vomited. He was vomiting, and they just zipped it up and put do not open. He, who was so well dressed and beautifully made up, died and was buried in his own vomit. I'll never forget that.
And that's part of the stories. Thank you for sharing, Anthony. I'm almost kind of to tears. That's part of the narrative that fed the whole HIV/AIDS treatment response. That's part of the narrative that we have forgotten, that we're taking for granted now, because there's PrEP, there's medication, there's treatment. People literally died from not having support, from not having treatment. There are people that, and their names that are coming to my mind that I don't even want to mention. But I remember being at this gay man's funeral who had died from AIDS complication, and his body stayed outside the church for hours because the pastor refused to come in community service. And I remember being at the graveside of this individual, and people may know who I'm talking about. And there was a dispute, between Friends for Life and his family. And his family were blaming Friends for Life for giving him, for his gayness and for him giving him HIV. And I couldn't fathom that level of hate at that time. For me, I was emotional. I was moved because he had died, but because that tug of war was unnecessary. And that's part of what drove the epidemic in the very early ages. Part of the fear that people had about HIV and AIDS, part of the thing that needed to be challenged. When I realized that I was living fine, I was healthy, my CD4 was good, my viral load was fine, I can move around much more healthier now. I began to question, why is there this stigma and discrimination around people living with HIV? And what was needed to change it? And those stories and that belief is what made me become the advocate that I am now, in terms of speaking out about stigma and discrimination. Yeah?
Wow.
I see you putting up a hand.
Yeah, I think this is, and it's for those who were not there and don't have these kinds of stories, it's not that we are focusing on the bad, but we are trying to share and still process what happened, the trauma that our community went through, that some of us are still, living with today.
And I think really it's important to understand that it still shows up, particularly in our community, particularly around dating, particularly when you go to hookup sites And people ask you, are you clean? I'm like, what the fuck? I showered this morning. Like, they're like, there's this thing about, I only want to date people who are HIV negative. I don't date positive people because you're dirty. Those things are still coming through today in how we engage with other folks. Even here in Toronto, there's a whole issue around people who are disclosing. If I don't disclose my status, I could be jailed. You know, it's a criminalization of HIV that happens here. And it still continues. And for us to recognize that the fight for HIV is still something that's ongoing. It's not stopped. And we have to keep pushing, because if we don't keep pushing, there's a pushback that can come, particularly with COVID that's happening now. Yeah.
Faye, you had your hand up.
Yeah, David just touched on it just now, because I was about to say that the stories that are being told are still happening today. And I'm saying today because it was just about a year ago that Estwick was telling me of a friend that was sent to Mount Hope because he was ill. And that the nurses had him sitting in a room by himself because nobody wanted to be around him. Nobody, because it was suspected that he may have had HIV, and they didn't want to deal with him, and the person was just sitting there alone. So as David just said, the fight, the activism around HIV, the education that has to happen, the care that has to happen, needs to happen, needs to continue. We need to push it more. We've gotten, I think, a bit lax because of all the drugs, and because we have people who have been living with it for decades and still having a very healthy life. So we somehow the message has been lost, because it's like, okay, so there are other stories that are coming up now, but we still see the same kind of stories that we saw 3 decades ago.
That's true.
Okay, you know, people, and that's where I wanted to go to next, and sort of bring Brandy and Luke in, because we sometimes believe that, yes, these stories are important, but that was the past, you know, that can't be happening today in 2020. So Bran, I know you have your hand up, but let me just bring in Luke, as David mentioned, Friends for Life. And Luke, maybe you can, you have the Pride Memorial on Sunday that's coming up, and maybe you can touch on that as well, and share what you all are planning to do this year, but at the same time explain to people why Pride Memorial was important and still is, and at the same time join David in sharing about Friends for Life's work, perhaps a little bit about where you all started and some of the challenges that you all faced in dealing directly as the primary caregivers in some instances for persons living with HIV/AIDS. Luke?
When Aspect started Friends for Life, I mean, those were the times, I guess, that Anthony is talking about and David was talking about, where there really was no medication. So it really was about caring for people until they died. And Aspect had a very strong passion that nobody should have to die alone. Because those issues around the family members rejecting you, even people kind of staying away from friends, not talking to them, friends rejecting you, those things happened. And what we realized is that people just kind of either died in the hospital alone or died home alone. And so Estwick kind of very expertly coined this, the name of Friends for Life, because it essentially was at that time making sure that you befriend somebody who was HIV positive, and that you did so for their lifetime, however short that was. I remember the incident that David was talking about, and I also remember very clearly that leaders in Friends for Life like Jackie and supporters like Cyrus literally took the body up and walked the casket to the gravesite. Cyrus performed the last rites. And all of these things were contentious for the family, but for us in Friends for Life, it is so more important that we stand in solidarity all through their life and even in death with our brothers and sisters. Because, I mean, I shared this I talked about this, for the Pride Memorial on Sunday, that like we've lost so much, but in spite of that, we dare to love so hard. And I think that was the true testament of how the community came together to support themselves. One of the things that we kind of talked about in Friends for Life was this notion of wraparound services, so that even when medication began to come on, how do you get people to go on medication, and what support do they need to stay on medication? And those are all kinds of things, even from the very mundane and simple as having a beach line with persons, or something is very complex as therapy to undo a lot of the hurt and a lot of the trauma caused by homophobia. We still see those kinds of things lingering today. And when we talk about the response, about the national response, kind of what we see is that when the NACC came on initially, there was a huge thrust back then to pump money into HIV and deal with the epidemic, and that has that has waned over time. And so we found ourselves now that even though the NACC is in the office of the Prime Minister, in some respects people feel like it's tokenism, because the resources that are pumped into the NACC to be able to do their work are so few. And it comes to the point where we've been talking about money that, like the question that David asked, money that goes towards key populations. And what does that look like? What percentage does that look like? And we've been talking about that for a long time, but still in Trinidad and Tobago, we kind of come up against a wall when we try to engage with politicians to say that very clearly, that we have to prioritize key populations, and we have to do that in a way that pumps money into the work that we do. I am stumped. Did I say everything? I think so.
Tell us about Sunday.
Beg your pardon?
Tell us about Sunday's memorial and what you're planning this year.
Oh, yes, thanks. So we want to talk about Memorial a bit. Memorial started in 1995 or 94, I believe, a decade and some ago. And essentially, people were dying so frequently. This was kind of trauma-inducing. It was gut-wrenching, and it was a feeling at the pit of the stomach of persons. And we wanted to find a way, how do we deal with this grief? How do we deal with this loss in a way that's productive, in a way that promotes our healing? And that's kind of where Memorial came out. Things like the names list and the photo wall that Cyrus developed, ways that we try to remember. You see in the States where they talk about, particularly when trans persons are killed, like you call their name, say their name, and there was such an importance of that. And even having the pictures for us to be able to venerate and contemplate as we are at Memorial, to remember them. And what it took on another set of importance, because a lot of persons, because of the stigma of HIV, because of the stigma of being LGBTQ, their friends or sometimes their family didn't want their names read out, didn't want their pictures up, because they didn't want anybody to know. Even, I mean, up to this year, it is so tragic. Up to this year, I had a friend die, and his best friend, who is a nice, I'm gonna say young lady, but she's not young, who's a nice lady, she kind of told us that she did not want us to do anything for him that was public because he was not out. And it hurt me to pit in my stomach, because in many respects, I did kind of respect her. I didn't put stuff up on Facebook. I didn't make any comments. But at the same time, like, I feel like she doesn't own a monopoly on friendship. But even in this time, that still happens. Even in this time when you think that Pride celebrations are so huge, that there are so many persons who the stigma is so strong for, that even posthumously, we cannot say their names. And so that's why Pride Memorial has taken on such a huge meaning for us particularly the older ones in the community. This year, we are not in a physical space. We normally have it at Black Box. This year, it's going to be very much like these sessions that the PrideTT are hosting. It's on online. It's going to be some platform. I don't even quite know, but the link is out there to accommodate the kind of viewership that we think we kind of need to. We need to be able to accommodate the viewership to be able to hold persons and provide that kind of healing that will come from being able to have processed grief in those ways. It's going to be the normal traditional time. I think it's like 6. We're going to get on before that. It's going to start at 6. We're going to try and do everything as traditionally as we can. So we're going to have a feature just like we normally do. We're going to have comments from Friends Life like we normally do. We're going to have the names list and the photo wall like we normally do. And we're going to have candle lighting like we normally do. And then there's some open floor. And traditionally, we've had like the Queen of Queens girls and things do their performances. And we're going to try and accommodate that as well. So that even for the persons who are at home logging on, that the experience so much so resembles the experience that they know from Pride, to kind of link this sense of tradition of the past meeting the present.
Thank you very much. And we are, of course, encouraging everyone on our networks to attend and to register, because we acknowledge how important Memorial is. And I just want to underscore, in case it missed anyone, Memorial is not just for persons that we lost through HIV. Memorial is for as many people, as Luke explained, that we are able to remember, because each one of those persons is something, a spirit, a soul that we lost from our community. And some of them we lost in very tragic ways, and others not so tragic, but we miss them nonetheless. Brandy, at this point, let's talk a little bit about our dear sister Sasha Fierce. And we touched on it on Sunday when we launched our memorial fund for her. But I'd like to use this as a bit of a segue, because last year, of course, we had a special tribute to her. To share with our viewers a little bit about her work, and then, of course, the work that you are continuing to focus on, and that you shared about her wishes and her dreams for the community, specifically in this area of HIV at the Trans Coalition.
Let me see. The position that Sasha last held in her work was she was an peer outreach person in terms of negotiating better condom use, always giving out condoms and lube and reaching out to people to get tested, and to have conversations with them about safety and more education on HIV. We had found this kind of networking, it worked really well. The younger persons, or the persons who are identified from key populations such as the sex workers, and more so the trans, non-gender conforming, and the persons who come from that spectrum, because of the fact that the stigma and discrimination was a lot more once you identify to be trans, or you identify to be non-gender conforming, or along those ways. So we create these employment to reach these persons from these various groups. And Sasha was one of the persons that was selected and actually employed at linkages to do the outreach, and also to educate about HIV, test and treat, and you know, how important it is. The navigators used to, on the other hand, they would reach out to us to say, well, okay, she would say, well, Brandy, I have someone to navigate, because I will take from her when she already have this discussion, we would navigate with this person through the system and continue navigating with them over a period of time. And navigation could be from 1 day to like 2 years until the person ready to actually let go to say, well, I'm comfortable to do this now, because we know what the challenges are. We know from what I've just heard from over the last 3 decades, much have changed, but nothing has really been done. And I'm saying this again in terms of access to medication has changed, technology has changed, living a healthier life has changed, but the stigma and discrimination still remains the same. And also, that is why I'm changing around the dynamics, because we had, over the last 2 decades, trans women were always left out of everything, even access to medication and treatment and care. We had them at least on the list. So, you know, I would want to still support, and my conversation is to put the trans, put the T in front of the L, the G, and the B for this month at least, until we could feel comfortable and say, well, okay, this is something worth doing. Because over the last decade, from all the persons that I have remembered over the years, were, it's easier to say, well, because of the language and the education, non-gender conforming and non-binary. But, you know, at 30 years ago was just trans women. Now we understanding along the spectrum where some of these persons we have lost, as where they were, and how we could identify with them now. And you know, the stigma and discrimination has not changed. So creating this Sasha Fierce funding is a big part of that, is also to talk about stigma and discrimination, and not only empower women, trans women, to become more academic, or to build skills and capacity, you know, but also to understand stigma and discrimination, and to work around these barriers that prevents, you know, treatment and care. So really thank you for having, you know, bringing up this. And also, and as Luke said, you know, we have to remember where the challenges are, and you know, we understand where we are with medication. We understand where we are, we can live longer. But you know, I still don't see all of that, because, you know, just in 2020, this year, I had to ask Dr. Sigrid to get a bed for a trans woman. That should not have been. These are the things that we're talking about. For Carnival, Cyrus could contest to this. I had to, you know, call Dr. Sibru and ask Cyrus to reach out to this person because of family issues and all other things this person was going through, who identifies to be trans, and also a sex worker. And they still had challenges and issues of getting a bed in the hospital. So I understand all the dynamics and all of that, but we just have to remember, I want us to work together, but not work independently, work together to change around the stigma and discrimination that surrounds HIV and access to treatment and care.
Bran, you know, while you're speaking, Cyrus is pointing out that even though HIV has now been classified as a chronic manageable condition, and of course, once you are undetectable, you cannot transmit the virus. He's also pointing out the double-edged sword in that you find there's less conversation and education, as we've touched on in the conversation tonight, but the virus continues to spread unabated. And that is the irony of it, that even though as you are saying, I think that's the same point you're making, that things are changing. But, you know, the old saying, the more things change, the more they stay the same.
Yeah, yeah, yeah.
And
So that's the disconnection. We seeing a lot of good, but yet still on the other hand, there's a lot of bad.
and 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 I want to bring David back in for a moment here, because you're also touching, of course, on some points that he's looking at as well, which is the issues of intersectionality and the social determinants of health. David, tell us more about that. I mean, from your perspective, again, your work both in Trinidad and abroad. Uh, Explain some of these issues for us. How did they operate in time gone by, and have they changed now, or are we still seeing the same issues today? You're muted. Just unmute, please.
I think there are a lot of issues that are still similar. I think risk perception is a huge thing. That the less risk that I perceive, the more I'm inclined to take chances. And so for a lot of folks, I think if you look at a person, they look healthy, they look a particular way, as you see in the Caribbean, they have clean skin, no marks on the body, we make the assumption that that person is safe or clean. And so that's part of the conversation, I think, as well, that we look, I feel that's part of what may be driving the new infection thing. Also, I feel that we have to look, particularly when we talk about stigma and discrimination, we have to recognize that human beings are complex. We live with complex identities. And these identities impact upon how we negotiate our sexual health, how we make relationships, how we negotiate pleasure, how we access testing and treatment. So for me, I am a newcomer, migrant, a person of color, a gay man, an HIV positive person. I'm managing all of those identities at once. And how those identities impact my access to testing, to treatment, and to care. Yeah? As a person of color, I have challenges around accessing particular health centers because I feel that they don't understand my language. They don't understand my culture. They don't understand where I come from. As a migrant, I may face barriers because people don't want to deal with migrant populations, or you're bringing in new infections, for instance. And I think we have to look at intersectionality and how that plays out in our populations that we work with. When I speak to social determinants of health, we're looking at issues of housing, food, financial stability. Those things play a key dynamic in how we look at taking care of ourselves. So a lot of the HIV treatment programs here, they do a lot of focus on food banks, for instance. They do a lot of focus on housing. The focus is on community building, because they recognize that those things play a role in terms of how we access treatment and how we stay on treatment. I hope I answered the question.
No, I think, you see, and I mean, the time is against us, of course, because these are very complex issues that require much unpacking. And all of us experience these things differently, whether you come to it from a point of vulnerability, a point of privilege, or in between. As you mentioned, you know, all of the other social determinants that color the way you look at these issues. And as others on the call have said tonight, it is only through continuous collaboration and sharing can we really move the needle forward. So, Luke, I want to ask you all for a round of closing comments at this time. We will, as I said before, have many more of these, and we will be harassing you all to continue to work with us. So, David, Mrs. Martinez will be able to speak with you even more and see you until you can visit us again. So, yes, but Luke, in your closing remarks, again, what is the call to action within the community? I like to focus in on the community sometimes, because we look outside, which is important, and we look to allies, but we as a community are differently impacted, differently abled, different social determinants, what would be your call to action for all of us in the area of HIV/AIDS in particular, and how we can continue this work and get it done? Because it's, as Brandy said, it's change, things change, but they're staying the same. What are your closing remarks and call to action for our community?
Oh, that's fantastic. It's so important I think for us to be content creators. And I know that it seems very far removed from the conversation of HIV, or far removed from the conversation of mobilizing the community. But when you are in a space where you're alone, if you're a new person coming out and you're looking, when you pull up on Google, the things that are really hitting the mark, that come to the top, and not necessarily the things that we're putting out there. And so if more and more of us create content, it means that the chances that somebody living in a very rural community, down in the south, wherever, they're going to be able to pull that stuff up. And so recording these things, making sure that it's live, the kind of things that Queer Corner, like I'm so enamored, I hope that's the word, by the work that Queer Corner is doing, because of the fact that they just put in pure LGBT content out there without any kind of explanation. We're not here to explain to you why we're supposed to be here. We're just existing in our space and putting that content out there. And those are the kind of things that Friends Life kind of wanted to do as well, so that even with the memorial being online, instead of just doing a kind of online stage performance, but that rather that we create video content that we can play, also that the things can be consumed at different rates. And so it's the videos that talk about our lives, it's the research that you want to do to put out, the kinds of things that Friends Life is partnering with SCJ to do on family support, on what are the policy concerns for, and I know you're doing this too as well, Rudy, on policy concerns for the LGBT community, particularly in this time of election. I think those things are the most important things. And I think if we get all those things right, that trickles down to very many spaces. So it means that the persons who are HIV positive, they will also get a platform to speak, and we will also be able to kind of understand their lives and their experiences. It means that young people, even though funding for HIV is plummeted, kind of what Donna was alluding to, that if a young person pulls up anything on queer PrideTT or the other blogs or Facebook sites, that they're going to be able to get that content to pull up. And especially for those young people who would have tested HIV positive, as David was saying, what they do not see are not images, what is that thing, boy? Advertisements or posters or banners that make them feel disempowered and make them feel cringeworthy and unimportant, but rather that we put stuff out there that is super supportive, and they know that they can get the kind of treatment that they need. Just to go back to PrEP, when we talk about consultations with the community and what it means to be kind of culturally competent around dealing with the members of the community, very much like David was saying, his experience as Indo-Caribbean person living in Toronto, going into a space and some of those centers, they don't understand it. So it's not just that they don't understand the fact that we're talking English. They kind of don't understand where we come from. They don't understand why it is we prioritize things more than others. They don't understand why it is when they tell us something once that we kind of walk out and we go, I'm not doing that. Oh crap, where was I? All right, yes, cultural competence. that is so important. When I lost my train of thought there. I was going to talk about cultural competence. David, could you kind of help me out here?
I'll try, Luke. You're brilliant, so let me see if I can match your brilliance. In terms of cultural competence, what you have are people who are accessing healthcare providers, but they don't understand the nuances by which we communicate and how we express ourselves. So if a person says, like they may shrug their shoulder or may fold their arms, the practitioner seems to think that that's actually your refusal, or it's like how you read body language, how we communicate here, how we communicate as Black people, as people of color, as opposed to our white counterparts. It's very, very different, and it's read very differently by our healthcare providers. And so sometimes the way that we do it is often not seen the way that we meant it to be. The way that we see it does not come across the way that is not interpreted the way that we think is going to be interpreted. Am I right? Look.
That was perfect. Thank you so very much, David.
And there you have a perfect example of us working with each other to unpack these issues.
So, Rudy, in terms of, can I just say something about PrEP?
Yeah, sure. Go ahead.
Very quickly. I agree with some of the sentiments earlier that PrEP is a program. I understand so what we have, there's stigma attached with using PrEP. Stigma, particularly if you're a person of color, if you're using PrEP, you're seen as being someone who is promiscuous, who is just having lots of raw sex because they want to. Even among the Black community, that is something that's popped up quite a lot. The fear of accessing PrEP because you don't want to be seen as that person. You don't want to be judged. Even though PrEP is available, even though it's somewhat affordable, and I use the word somewhat, and there's strict protocols, there's still issues around access for Black communities, simply because of the stigma attached to using PrEP. And that's something that we're working through here.
So, David, on that note, would you like, I know you've touched on it earlier in the conversation, but for your closing call to action and ours to you simply is that we are going to lean on you. We are going to take you up on your offer to help us to develop programming and see what we could learn from your experience and continue to bring you and others in to our ongoing programming. But again, just to reiterate your call to action and your advice in this area in particular as we wrap up tonight.
Okay, so thank you again for having me as part of the panel. As I said, I'm not there physically, but my heart and my soul still is there in the work. One of the things I've been actively thinking about over the last couple of days, because I've been privy to these consultations that have been happening online, these private meetings, as well as a radio, that show that Lewis does. I was on that show as well when you appeared yesterday.
Femcom.
Right. Badassery, for want of a better word, and had me thinking about the ways that I can engage folks here to support the work back there. And oftentimes I feel like there is not enough sharing, so people don't understand there's a way to collaborate that can happen, not just within Trinidad waters, but can happen in Toronto. So one of the things I've been thinking about and actually planning on is to create an online platform where I invite NGOs from Trinidad to talk about their work, and they will be listened to by folks who are in this diaspora. Key players are the key partners here who can, in fact, find ways to support what's happening there. Yeah, and so that's something that I've been, I'm working through the details of now that I would like to see happen in the foreseeable future.
Wow, fantastic.
So what it will be is, like, for instance, I may have Friends for Life on, and Friends for Life, we talk about their work, but who is listening to the conversation are not just people from Trinidad. It's people who work in Toronto, who are key partners and who are key players who can actually say, oh, we can support you in this way, we can offer this type of resource, we can offer this kind of technical expertise, we can collaborate with you on this path. And so I feel that's something that we can look at actively doing.
Yeah, I just want to say, David, that I want to recognize that last year, I think you actually did do that. I think there was a time when was it around Pride? You had a group of different persons in Toronto, and I was able to talk about the work of Friends for Life and talk about partnerships and how they can support the work, how persons in the diaspora can support the work back in Trinidad. And so thank you for that.
And that's something I feel that needs to be ongoing. And so people, like I heard quite a corner story yesterday, I was so impressed with them, but I feel like they need that kind of support as well. So there are things I feel that we can do here to support a lot of the community work that's happening there. And that's something I would like to continue to facilitate.
No, 3 chairs for that, David. We need to, we need to bring everybody in on around the table on this, and we cannot do it alone. And that kind of platform that you would be able to provide in that territory would make a big difference. So yeah, let us know how we can support, and we will definitely partner with you in helping to bring that to reality. So thank you for your time as well, and you and Luke. So Bran, you Trans Coalition organized this for us with Dr. Sebrew and Mrs. Martinez, and you shared a lot on the call about some of your activity. As we wrap up, your call to action, reiterate your position. What do you need from the community, and where do you see us going from here?
I would say what my needs are from the community is to see.
Oh, sorry, Bran. Sorry. I wanted to just share this with you because you may not see on the Facebook Live, but Miss Wallace, who we know, both of us know very well, she's sharing with us that the perspective that transgender people would not live a comfortable life in Trinidad and Tobago because the system isn't working. And also what we're discussing here tonight is perhaps why HIV positive persons have to seek help in other territories around the world, what we call first world countries, especially transgender persons. So I'm sure that would color your closing remarks. So sorry for interrupting you, but I wanted to share her comments with you.
Yes. I must say, continue the conversation with about what Mrs. Martinez left in terms of solidarity, and continue for us to work together in numbers. And I also would want us to support what our needs are, continue to ask, as a group, what our needs are, and if to take into consideration that although much have changed, we see little has been done because the stigma and discrimination around HIV is still existing even after 3 decades. And we need to move this stigma and discrimination, turn it around, because at the same time too, why we contemplating on PrEP is more so that the sex workers, the trans women, and the coordinal couples could have a better life, and not to be judged, or not to be, people having to talk about, HIV in such a way or in such a term. And I also understand the fact that my trans sisters and brothers are seeking, first world country because of housing, because of insurance, because of things that they're not getting in Trinidad and Tobago. But at the same time, there is still a different kind of thing. It might not be HIV, but stigma and discrimination is still surrounding my trans community brothers and sisters. And that is still going to be a conversation. But if we could live and try to be happy and try to work around, because I have understand what stigma and discrimination, that I know what stigma and discrimination is, and I have turned around the stigma and discrimination to make it work positively for me. It made me become a very unapologetic person. I am here, and I am not going to, I have no regrets. I have no regrets as a trans woman, but I just need to see more done, and let us engage in a positive way to support each other.
Well, thank you very much, Brandy. And we understand that the challenges that are faced here, while they are not unique to us, they happen all over the world. But in some places, there are obviously different support mechanisms that we can look at here. So we call on all of us across the globe to hold hands in solidarity. And I just wanted to close off tonight by introducing a young man. I was asked to be a judge at the Miss Queen of Queens pageant last year, and this young man presented a piece of poetry that has stayed with me since then. And I told him I fell in love with his heart because it spoke to me in volumes. And I would like to introduce Kenson Laudat. He's going to close off tonight with a performance of his piece called Wrong Turn. And I will let Kenson introduce it and give you all some more context. And I really am glad that that Kenson stayed on the call. He's been on the call all the time, waiting for this cue. And we promised him this opportunity. But Kenson, thank you so much for agreeing to do this for us. And I'm sure everyone will see what I'm talking about. So over to you, Kenson.
No problem. Thanks for having me. This poem was written after one of my best friends confided into me that he was HIV positive. AIDS has been around me for a while. It just took me a while to notice it. When I was younger, a very close friend of mine was born with the virus, and she died at the age of 8. Then another friend of mine who was murdered after being said to us that he had the disease and it was contracted by one of his past partners, and they took revenge with the cost of his life. And then a few years ago, my best friend, like I said, confided into me, telling me that he himself didn't know who he got the disease from. And it hit me in a particular way that I didn't know how to cope. I didn't know how to deal with it. It was a bit selfish because one, it isn't me, but at the exact same time, I couldn't help but think about the relationships and the bonds I may have to give up one day, and some of the trauma that I would have seen these individuals go through at a young age. And yes, now AIDS is no longer the death sentence it once but some parts of me deep down feel angry because there is no form of honesty or respect for a person's life. So I wrote this piece called Wrong Turn. It is a piece that speaks about relationship that is not truthful and how one's life can be easily lost under the pretense of love. So this is Wrong Turn. You know, skeletons weren't all made for the grave. As a matter of fact, I had a few buried in my closet. And then one day I got tired of hiding and decided that I'm going to take them all out. And for the very first time, I felt free. So free I can fly. All the way up in the sky, I can finally embrace the rainbow. Sleep on clouds. Taste the wind of freedom that would bring me new change. And indeed it did. And in the form of a dark cloud, there you were, with lightning bolt in veins, sculptured like my future. I fell in love with danger. And wherever he reigned, I was always sure to get wet. Little did I know that his beauty would bring me death. He pledged to remove all my hurtful scars, promised me the moon and the stars, engaged me with a ring, ensuring that I would never have to question him about a thing. But this thing was destined not to last. Thanks to Tom's Dick and Harry, yes, that was his name. I remember having to have many walks of shame trying to figure out who can I blame? For this internal pain was driving me insane, and every time I picture his face or someone bring mention to his name, I always have to see a little bit of my sanity leaving me. And there I am in the dark room, all alone, with the screams of my mother saying to me, "You're the reason why God destroyed Sodom and Gomorrah." The nurses them telling me, "You ain't gonna live much longer." I wish that this 12-step program would have led me away from you. So here I am all alone, staring in the mirror. And for some reason, I see my future. And for some reason, I couldn't help but to keep my voice down, but I had to scream out and say, "I'm sorry. I'm sorry. I'm sorry I didn't know any better. No one told me that you are more than grinder, tender, a nigga 6, 7, 8, 9 bed warmer. I'm sorry. I'm sorry that I never even questioned the importance of using a condom. I'm sorry. I'm sorry that I never even asked myself why you never looked me in the eye when you made love to me. It all makes sense now. The eyes are the windows to the soul, and you clearly have none. And here I am now with my arms tied, welcoming an unwanted friend. And only then I realized that no longer can I duck him again, drunk or sober. We're best friends forever. Don't bother ducking or running for cover because he has your number. 22 years now, 43 again to go. Wishing that no was the only word you didn't know. Being a hoe is no longer a winner amongst friends when you're the only one who is losing. We're losing, they're losing, we're dying, we're dying. He's not our friend. So why pretend that we are invincible? To patiently pop pills every day, practicing a prayer, hoping that God can take him away, when all he wants to do is just stay. Putting his hands on my shoulder, tapping me, asking me like what we're going to do today, and he's right. I am in an unwanted arranged marriage. And in this fight, I cannot win, for I have committed the ultimate sin. I have been deceived to believe that you wanted me, cared for me, loved me, but you never loved me. Where was your loyalty? Where was your honesty? Where were those promised words that you would never, never hurt me? It's funny how your LOVE gave me HIV. That's it.
Question. My God, amazing poem. Amazing. You have to read this and read this and read this. I mean, amazing. I love poetry and I love you. And this made my night. Thank you.
No problem. You're welcome.
Wow.
Wow.
Well,
Wow.
folks, what can we say after that? I normally give all the closing reminders, but I will just say, be empowered by our pride. PrideTT is here for you, and this is what it's all about. So thank you, everyone. Our panelists, Brandy, thank you for helping us get Dr. Sebrew and Mrs. Martinez. We will, of course, extend formal gratitude to them. You and David, Luke, everyone else, and of course, Kenson with that powerful piece. So continue to support one another, continue to love one another, and let us rise together. Let us be empowered by our pride and take our community forward. I hope everyone is safe and enjoys the rest of the weekend, and tune into PrideTT for more activities as the month proceeds. Love you all. Take care. Bye-bye.
Bye.
Really? Faye.